All right. So let's pick up where we left off. All right. So super brief. One of the things that triage nurses in the OBGYN world, after the patients have discharged from the hospital, one of the things an OBGYN triage nurse might hear about are people who might have a breast mass who are breastfeeding or lactating. And it is possible to have a progression where someone has a plugged duct that will lead to a mastitis, which is an infection in that breast or chest tissue, and that can then wall off and become an abscess. Okay? So here are some key things to know. It's a plugged duct if someone has a tender mass. If they apply heat to it, like moist heat, like a warm, moist washcloth, not enough to damage the tissue, but enough to dilate the vessels, right? Okay, to dilate the ducts. Okay, if they apply heat to it and massage it and have the baby nurse on that side first, the first side the baby latches onto is the one that they nurse most vigorously on because they're hungry. They can hopefully drain that plugged duct and open it up so that it prevents mastitis from developing. It is possible to do that, to prevent mastitis from developing by working on a plugged duct. When a patient has mastitis, they have all those same symptoms, right? They have a tender mass in the breast. They may also have redness and swelling, but the real key for diagnosis of mastitis is a fever. They are febrile. A plugged duct is not febrile. The distinguishing symptom is really a fever. If they have a fever, they need antibiotics. There needs to be an antibiotic that will penetrate soft tissue, like a Keflex, right? An cephalosporin like Keflex or dicloxacillin are the most common. They should also continue to nurse the baby. Continued lactation is important because no one will drain the infection better than the baby. And guess what? The causative organism usually came from the baby's mouth. It doesn't hurt the baby. You're not going to infect the baby. The baby is usually the source. All right? And the baby can help fix this, right? The baby can help fix this. By the way, people with mastitis sometimes feel like they've been hit by a truck. They're febrile. They feel awful. You know, they feel awful. That's something to know. Usually, by the way, they'll start to feel better when an abscess forms. Yeah, it'll wall off and become kind of a soft mass. The unfortunate thing about abscesses, though, is that they typically need to be surgically drained. So that's why we really want to get on top of mastitis and treat with antibiotics. But if we can catch this in the plugged duct state and drain it, we can even prevent mastitis from occurring. Another thing about prevention and treatment is rotating the different positions and knowing the different positions, so that they rotate, whether it's a clutch hold like a football hold, or a cradle hold, or a cross cradle, or side line hold. So rotating those, right? So, pardon? Vibration, yeah. Yep, break that up. Yep. Massaging it when the baby is latched on is helpful too. Mm-hmm. Yep, definitely. Yeah, so all of those things are potentially helpful. All right. So who do we call when we have trouble? When we have signs of difficulty, or maybe somebody who needs a good dose of prevention? Lactation. Yeah, the lactation consultant. Yep, the lactation consultant. And there are postpartum care centers, especially in Washington State. It was required by state law that insurance companies pay if patients were discharged 24 hours after a vaginal delivery or 2 to 3 days after a C-section. It was required that insurance companies pay for follow-up visits. And those are nursing care visits. It was nursing care that people weren't getting. So like the postpartum care center at Providence is a nurse-run clinic, okay? And the insurance companies had to pay for either a nurse visit in the at the clinic, or they had to pay for one as a home visit. It could be a home visit. So some hospitals have home visit programs as well, right? All right. So diastasis recti, the rectus abdominis had to spread for that uterus to grow. So it's very common for there to be a small gap between the muscles, right? This is not something we are imminently worried about while the patient is trying to recover from a C-section, right? C-section people should not be doing chin lifts just yet, right? But they should know that doing things like chin lifts and shoulder lifts, doing some abdominal crunches is a good thing when they feel rested and ready to do that. It is not a priority. But I do want you to know that this exists and that working on abdominal muscle tone is something when a patient is ready and rested. Okay, but not a priority. You should also know that full involution, full contraction of the uterus, and an involution to a pre-pregnant size and state takes 4 to 6 weeks. That's the magic of having a 6-week checkup. We're making sure the uterus is fully involuted. Lactation helps this process. So does an empty bladder. Subinvolution is when we do not have adequate contraction. Medications like Methergin can be given. Often it also correlates with bleeding too, right? Subinvolution means the uterus isn't contracting well enough to stop the bleeding. Okay? Endometritis is an infection inside the uterine cavity. If a patient has choreo, they can get endometritis. When we examine the uterine fundus, which you already know about, right? We are not just checking whether it's deviated and the height. We are checking for the sort of tenderness that people have when they get infected. When people have endometritis, they also feel like a truck hit them. They look very pale or gray because they just have that. Have you ever seen a patient who's septic? You may see a patient who's septic and they don't look very good. They just kind of look washed out. That's how people with endometritis, and they don't look like they have energy at all. Like, I mean, there's fatigue, and then there's a whole other level of fatigue. They're that whole other level of fatigue. Very fatigued, very, very pale. Obviously tachycardic. If somebody is infected, they may have tachycardia as well as fever, and they will have a tender uterus. It's not just sore because they gave birth. It is the sort of tenderness people have when they have inflammation on the inside of their bodies. Okay? Endometritis, the etiology is usually ascending bacteria during birth, including strep and staph, but also others. Okay? So this is strep. The incidence after a vaginal delivery is less than 1 to 2%, depending on the research study. After a cesarean section, the rate varies according to the researcher and the research that's done, but it's between 10 to 20 times the risk of infection compared to a vaginal delivery. And this is the best data that we have, the largest data, and the one that's currently cited by CNQCC and the CDC. Okay? So this gives you a relative risk. Okay? So it's the odds ratio. So if vaginal delivery is 1, the relative risk of infection with a primary C-section without labor is 10.3 times the rate of infection. Okay. If it's with labor, it's 21.2 times. If they had a repeat cesarean without labor, then it's 9.9, so roughly 10. If it's with labor, it's 14.6 times the relative risk. So that's a really significant increased risk. This is why, anybody see a C-section? Anybody notice that they gave the patient something, a prophylactic?
No, but I did see him stick a whole sponge all the way up the vagina and betadine.
Yeah, we don't usually betadine the vagina, to be honest, but that's a little unusual. Yeah, yeah. Yeah, that's not usual. Yeah, we certainly do use a good prep, and you might notice they time the prep if they have time. But yeah, we don't normally betadine the vagina, just saying, that seems extraordinary.
I thought so too, but hey, not
Yeah,
all
no,
I know.
yeah, you are correct on that. Different people come from different hospitals, and we're mixing a lot of different people from a lot of different places. So I can tell you that's not usual process, but maybe that person comes from a hospital where that's done. So, um, but anybody notice any medications we give them? No. 2 grams of Anseth is routinely given. It's usually written on the whiteboard and usually stated when they do the timeout. Usually the surgeon asks, has the Anseth been given? We make sure that we give them 2 grams of Anseth within a half an hour of that incision. So every patient for a C-section needs antibiotic prophylaxis, and this is why. Every patient. So again, we're planning for recovery before the recovery happens. And we're looking at the relative risks of the things we must do to keep people safe. Okay. Risk factors, well, obviously C-section. Cryoamnionitis, if they develop an infection in labor, right? Prolonged labor, AROM, artificial rupture of membranes. Did Michaela have that? Prolonged rupture of membranes, which is more than 18 to 24 hours. Some researchers say 18, some say 24. All right. Internal monitoring, a scalp electrode or an intrauterine pressure catheter, right? Presence of meconium. And it's hard to say, I don't really believe it's meconium that's causing that. It should be relatively sterile if it's inside the baby, but I think it represents more of a correlation with interventions. When a baby has meconium, sometimes it's because they're stressed. And then we do more to those patients and they have more vaginal exams. Colonization with GBS, chlamydia, mycoplasma, ureaplasma, or bacterial vaginosis. EV increases the risk. More than 4 vaginal exams in labor. Of those of you who have seen a birth, raise your hands. How many of you saw patients? Keep them up if your patient had more than 4 vaginal exams. That was most of you, right? Or do you know? Pay attention and see. More than 4 vaginal exams is very common, but it increases the risk. Anemia, right? If you have fewer WBCs and a lower crit, H&H. Low SES, socioeconomic status, potentially related to the risk of anemia. If people don't have enough money to eat well, it impacts their ability to fight off infections and recover. There is a very real connection between the social determinants of health, right? All right. Endometritis, our symptoms. If we are monitoring our patients and assessing our patients postpartum, fever, tachycardia, hypotension, uterine tenderness, and again, it's exquisite tenderness, foul lochia. It doesn't smell like hamburger. It smells like it's infected. I can't bring you smell-o-vision, I'm afraid. You're welcome. Heavy lochia and malaise. True story. I have a very poor sense of smell. I have been virtually sitting in foul lochia and not knowing. I used to have to ask people to tell me. Yeah, I have allergies. I consider that a good match, right? Heavy lochia and malaise. Again, you can see that association with chorioamnionitis, and the malaise is, like I said, it's a whole nother level of fatigue, right? You might see the patient looks diaphoretic, right? I chose this picture because you can see she maybe her face looks moist, right? Her face looks moist. So diaphoresis can be a part of it too. All right. Our workup is a CBC and ultrasound for retained fragments, because retained fragments can also lead to infection. Retained fragments, clots, or fluid inside the uterus, and the treatment is typically antibiotics, but the regimens vary. It can be doxy, metronidazole, levofloxacin, ampicillin, ampicillin with gentamicin, clindamycin. It will usually be which is septicemia, right? The infection travels through the body. Sepsis can lead to septic shock. You will learn about shock next quarter. And that can mean multi-organ failure. So the blood pressure drops enough that major organs are no longer perfused. So remember that this is one of our leading causes of morbidity and mortality, right? That's how this unfolds if we don't catch it and treat it. And that's why it matters things like, you know, whether or not we do vaginal exams, right? And how many we do, and how long someone's membranes are ruptured, and, you know, trying to prevent C-sections when we can, and why this all matters, right? All right, so our other infectious processes include mastitis. Wound infections can occur. UTI, including pyelo, right? We're doing all those caths sometimes, right? UTI is possible, and thrombophlebitis is possible as well. So our other inflammatory conditions to watch for. VTE. So let's getting into the cardiovascular. All right. And by the way, look around the room, all the lovely people who got born and who are all okay. Okay, because I realize I'm kind of going through this hit parade of things that can happen, right? Most of the time it doesn't. But we are on guard because we want to stop, we want to prevent it, and we want to stop it in its tracks if it happens. We want to keep these things from any of these things from escalating. So VTE is another serious concern. And this is from our friends, these protocols are from our friends in California. Venous, and as you might remember, venous thromboembolic disorders. All patients should be assessed for VTE risk at multiple intervals in pregnancy. So just like you were assessing for risks of hemorrhage at different times and preeclampsia, anytime we see somebody initially for prenatal care, we should be looking at their risk of VTE. Okay. Hospitalization for an antepartum reason. Birth hospitalization, or end up on discharge home. What is their risk of having a clot, having a DVT, throwing a pulmonary embolus, having a stroke? What is that risk? Remember that estrogen is a thrombophilic hormone. The biggest period of time of risk is after birth, postpartum, and then after that, it's late third trimester. The more estrogen we have, the greater the risk. But there's some other things that add to risk too, right? So on admission, if a patient is admitted antepartum, they should maintain, if at all possible, full ambulation. Are there people who can't fully ambulate all the time? Yes. What about that patient with a bleeding previa? Are we having them walk around the unit? No. How about the patient with preeclampsia with severe features? No, they're on bed rest, right? There are patients who legitimately need bed rest, right? Like bleeding previas and people who have bleeding previas and other things, right? But if we can, we want to maintain full ambulation, right? We need to ensure adequate hydration. We also need to utilize SCDs, mechanical prophylaxis. They need to be knee-length SCDs, not just the little foot ones. They need up to the knee while they are in bed, okay? So our patients who are antepartum on bed rest should be using SCDs, always. They also need to be placed prior to cesarean. Anybody see them put on during prep for C-section? Yes. When they did the timeout, they probably said SCDs on, right? They would have asked about the ANSEF. They would have made sure the SCDs were on, right? And we continue those post-op for all cesarean patients until they are ambulatory. Okay. Patients undergoing cesarean with additional risk factors for thromboembolism. Individual risk assessment may include not just compression devices, but heparin, unfractionated heparin, low molecular weight heparin. Okay, that's what this is. So Lovenox. So we might, now you're thinking, Susie, this patient's going to bleed. You're talking about giving somebody heparin who's going to bleed. Uh-huh. Yeah, I am. Yeah, have you ever noticed that OB nurses have a tolerance for a certain level of risk? Yeah, there is that. All right, so we've got this balance of risk, right? Coagulopathy is huge, right? Bleeding too much, but also the risk of someone having a clot. Right?
It's easier to put blood back
Yeah, there is that. Yeah, I like your thinking. Yeah. All right. So California did a study, and they looked at 29 patients who had uh, who had died. And they looked at their risk factors, right? They died from VTE in California who were postpartum. 61% had a BMI of greater than 35. In contrast, 28% of those who died of all non-VTE causes had a BMI of greater than 35. So we believe that this represents truly an increased risk, that BMI itself is a risk factor for throwing a VTE. Of those with a BMI of greater than or equal to 35 who died from VTE, 75% had a cesarean. So if our patient has a BMI of greater than or equal to 35 and is having a C-section, this is a significantly higher risk patient. And that's important for us to know. Okay? There are risk analyses. There are thrombophilias, so you're going to ask patients when you do a history, any bleeding disorders in your family. When you do your new OB history, right? You asked about bleeding disorders in the family. This is why, right? Also clotting disorders. You know, if you see somebody who had let's say they had a brother who had a stroke at age 25, that's unusual, isn't it? Could that be familial? Is there something genetically going on? And is that something we would tell in an SBAR to our provider so that we can look a little more closely at that patient, see what their risks are, to see if they need some sort of genetic screening? There are coagulopathies. I will not list them. I don't want you to memorize a list of coagulopathies because you have enough to think about right now. Okay. But they are things like factor V Leiden mutation, for example, people who have a variation called MTHFR, they have a folate variation in metabolism. There are metabolic disorders. You do not have to write these names down. I'm just giving you examples because there's always people who want to know more, and I want to give you that. But I want you to know where the limit is. Okay? And this is what I expect you to know. I do not expect you to memorize a list of coagulopathies and risk assessment tables for VTE. That would be unrealistic. I do expect you to understand and apply the following points. That prior medical history inclusive of genetics, BMI, bed rest, and cesarean are all key risk factors for developing pregnancy-associated VTE. SCDs are routinely needed before, during, and after cesarean. SCDs are also routinely needed if a patient is on bed rest due to complications. Ambulation should be encouraged whenever and as much. You can also add as early as possible. Okay. Sound pretty straight up? Yeah. Awesome. Cool. All right, so just a reminder of these. I think we went through them before. Perineal wounds and lacerations, right? Perineum. A first degree laceration is a tear through the skin or mucosa. They usually sting, but they heal well. Okay. Second degree goes into the perineal muscle. So through the skin and mucosa, and also then into the perineal muscle. A third degree involves the anal sphincter, a tear through the anal sphincter. Fourth degree goes into the rectal mucosa. Okay. Now then, how do we help a patient who's had a laceration or for that matter an episiotomy? Most episiotomies are at least a second degree. Okay. I do want you to know the leading risk factor for a third or fourth degree is actually an episiotomy. A perineal cut, once we've cut the tissue, the more easily it tears. And so they're usually extensions. Third and fourth degrees are usually extensions of an episiotomy. You never say never in obstetrics. That's just kind of a dare to the world when you say that. But most often the biggest risk factor is episiotomy. Okay. So we are going to monitor our REDA: redness, ecchymosis, edema, drainage, and approximation. We are going to do our pericare procedures, right? We are going to, first off, ice for the first 24, even up to 48 hours. It reduces swelling, it shrinks the vessels, and helps reduce and prevent bleeding and hematomas. Ice, ice, baby, right? And I think I told you, we just keep replacing the ice. We're not doing 15 on, 15 off. It's in the center of a very warm body that just worked very hard. It will melt. It's going to melt before it causes tissue trauma. So this is not like icing the extremity of a diabetic with peripheral vascular disease, is what I'm saying. This is at the center of someone's body that they're sitting on. So you see what I mean? So we just keep icing, okay? I would not use ice in this shape. It should be crushed. It should be padded, it should be padded. We should make this nice. There are very different nurses do it different ways. You could actually take a diaper and you take the tab side and you open it up and fill the diaper with ice. And they do kind of leak, but they're nicely padded. So that's kind of a nice one. The Prov does have ice packs that are shaped like a pad, like a peri pad. You can use those too. So there are various types of ice. Ice can also be used as a comfort measure for incisions as well. So ice is therapeutic. It's not, and it also helps to numb the area a little bit too, right? Peri bottle, filling it with warm water when the patient voids, they start squirting before they release their urine because it keeps the ammonia in the urine from stinging the tissue. If they squirt before they release, then they don't sting when they pee. Okay? The peri bottle is somewhat, just saying, peri bottles are best friends for the first few days postpartum. This is a sit bath. Okay? You might see those in the supply carts. Usually after the first 24 hours they can be used. This bag is filled with warm water. The patient puts the pan in the over the toilet seat. They lift up the toilet seat, set it on there, and they fill this with warm water. They release the roller clamp, and it kind of sluices warm water over their perineum, to provide comfort. All right, so that's a sit bath for you. Okay. Analgesics and anesthetics can be used. So acetaminophen is appropriate for them to use at home. So they can take that. They can also use topical anesthetics. There are different types of anesthetic sprays like Dermaplast and Americain or versions. So topical anesthetic agents are appropriate as well. Okay, they can be applied to the area. Frequent pad changes are a good idea for pericare as well. Padding dry, preventing constipation, especially for a 3rd or 4th degree. A high fiber diet, lots of liquids to prevent constipation and straining. Using a squatty potty or a stool so that they don't strain. We want to prevent straining. We also don't want them to hold their stool, so it gets harder and harder to pass and more uncomfortable. Okay? All right. All right. Cesarean? Are we going to follow similar vital signs for a patient that has a C-section? Yes. We're going to have our antibiotics, our SCDs, our chlorhexidine preps, right? Or chlorhexidine alcohol. Chlorprep is the one they're using at Prov, right? Right? We're going to do a good prep. We are going to be meticulous about our aseptic technique for anything that we do, our Foley's, anything, right? Because of risk of infection, right? And so are there additional risk factors and responsibilities involved with cesarean? No. Do we have to prep our patient? How do people feel when they go in for major surgery?
Scared.
Yeah, scared, anxious, right? Yeah. Are they getting excited too? All of them, right? Yeah. All of them. And this is a very, right? There are additional risk factors or responsibilities. There is usually a circulating nurse, a scrub nurse, or a scrub tech. There are also nurses who first assist in surgeries. That means they are scrubbed in and they're retracting and help suture and cut. If you see Ginny at the Everett Clinic, You see an Everett Clinic section, Ginny might be there. She's an RN first assistant. She does a beautiful, beautiful closing. Yeah, if I were having abdominal surgery, I'd request Ginny. But anyway, so just for you to know, if you go around the room, the leading professional credential in the room in a surgery is RN of some type. All the anesthetists that prop on OB units, they're all CRNAs. They're nurses. There's the NICU nurse. There's the primary nurse. There's the circulating. There's potentially a scrub. There's potentially a first assistant. Nurse midwives also first assist on cesareans. It could be a physician who first assists too, by the way. It just depends. Okay? Depends on who's available and the risk factors of the patient. All right. So, so be aware of that as well. All right. So all of those things are happening. Okay. So let's review quickly the learning needs of the family. Right. What do they need to know? Hey, they need to know how to feed their baby, right? How to feed the baby and to have some success with that. Okay. Is it an anxious time learning how to nurse babies? Especially people who've never done it before, they're worried about it. Yeah, absolutely. Elimination and diapering, how to diaper their baby. Okay. And so wiping from front to back, right? All that good stuff, right? Cord care. We want the cord to air out. We don't need to apply things on it. We just need it to air out and stay dry. Okay. These days, most people believe it's okay for the baby to have like a tub bath every 2 or 3 days, but the cord needs to air out. It is possible for the there is a condition called umbilitis, which is an infection of the cord stump. Historically, we used to use antiseptic dyes, and sometimes we used to have people clean it with alcohol, but the research hasn't found that that's actually helpful. But keep it dry if you're, and let it dry out after bathing. Don't let it stay wet. If the baby is circumcised, how to take care of the circumcision? Usually there's Vaseline gauze applied to the penis afterwards. Or replacing that, or using a dab of Vaseline after the Vaseline gauze is off. Because we don't want the penis to stick to the diaper. That would be ouchy. Okay? Sleep states of the baby, right? Normal traits of the baby. Car seats, right? Is there a car seat installed? Do they know how to use it? For the postpartum patient, breast or chest care, right? That can include wearing a supportive bra or vest to help provide support. We can also talk about feeding and diet. It's helpful to know that on average it's thought that somebody who's lactating needs about an extra 500 calories a day. It takes more calories to lactate than it does to grow the baby. Mm-hmm. Of course, it does depend on how much lactation the patient is doing, right? Elimination, right? Often people stool when they give birth. So if you see the vaginal delivery, did you see stool? Yeah, and that's normal. That's just normal. But we are expecting that they're going to have another stool within the next, certainly, hopefully, within a day or two, but no more than 3 days, right? Just like a regular adult patient, right? Elimination. And the idea that they don't hold back having a stool, or they don't retain their urine, that they void regularly, right? Incision or perineal care. Usually it's a suture and it's removed, depending on when they go home, it might be removed when they go home or in the postpartum care center. Only the external skin suture is non-absorbable. All the other layers are absorbable. For perineal care, by the way, if the patient has a perineal repair, those are all absorbable sutures. Typically, suture material, depending on what it is, will dissolve between 1 to 4 weeks. It really depends on the material. Natural materials like gut, chromic gut, dissolves very quickly within 7 to 10 days. Vicryl, monocryl takes 3 to 4 weeks. You do not have to know it in that detail. I just know that some of you like the extra detail, but I'm not going to ask you what suture material. I'm going to know that the suture's designed. Okay. All right, sleeping and rest. Best advice ever, sleep when the baby sleeps. Yes, they will. They will still be there. And I would also suggest learning, if you have it, if your patient says something about lots of visitors, talk to them about assigning those visitors tasks. Is it the sort of visitor who can help you with laundry? Could you ask them for help? Yeah. Sometimes people are burdened with learning how to feed their baby and up and down every 2 to 3 hours during the night and diaper changes. And then they have people who are coming who are, yeah, and who are wanting to be like house guests. No fair, right? Need to help. Right? And people want to help people want to help our patients with the baby, right? Yeah. Yeah. They want to hold the baby. No. Yeah, exactly. No. Yeah. Hey, we want to come over. Great. I could use some help cleaning bathrooms. That'd be wonderful. Right? Right. If they don't show up, you're a winner either way, in my opinion. All right. Okay. Exercise only when you're rested and ready, and gradually. Things like Kegel exercises, ready and ready. Once the stitches have healed, right? Once the incision has healed and people are rested and ready. Normal recovery and involution and warning signs. Let's talk about those. You might notice I have a thing for warning signs, right? All nurses do. Right? Whenever you discharge somebody, you review the warning signs, right? That's just routine. So what are our routine post-birth warning signs? A fever, okay, greater than or equal to 100.4 Fahrenheit. Unrelieved headache. Visual changes and disturbances. Dizziness or fainting. Chest pain. Shortness of breath. Increasing or unrelieved abdominal pain. We expect a little cramping. After pains and cramping are not unusual. But if we're having continued tenderness, that would not be, right? So some cramping, okay. But it should not be increasing. It should be getting better. And it should not be unrelieved. Heavy bleeding. I know you all know what that means by now. Facial or hand edema. Severe swelling, redness, or pain in an arm or a leg. Thoughts of harming self or infant. Overwhelming fatigue. Unable to take care of yourself or your infant. Okay? These are all serious, right? Remember that preeclampsia doesn't go away. Seizures can and do happen postpartum. Some of our patients are still on magnesium, usually 24 hours after delivery. Okay. And I know we covered that in the antepartum section of the course, but I want to remind you that it's still relevant. I also want to remind you that preeclamptics can go into labor and need care. People who are third trimester and bleeding can go into labor and need care. So I want you to carry this forward as we go into our third and fourth test. So don't forget what you've learned. It remains relevant. We build. We're building. Okay. Does that all make sense? All right. Post-birth, and I think I really covered it. This is a mnemonic device if you need a mnemonic device. P stands for pain in chest. O stands obstructed breathing or shortness of breath. S stands for seizures. T is thoughts of hurting yourself or your baby. The B stands for bleeding. I is incision that is not healing. R is red or swollen leg that's painful or warm to touch. T is temperature 100.4 Fahrenheit or greater, and H is for headache. So these are post-birth. These four, call 911. These, birth, you call healthcare provider. So 911, pain in chest, obstructed breathing, seizures, or thoughts of hurting yourself or the baby. These are 911 calls. Just help you. I feel a triage question coming on. Now I'm trying to be helpful and help you focus. So part of you. All right. So next thing, The next 6 weeks, we have taking in and taking hold as our stages, right? So anybody remember those from maybe you read, yeah, Rubens? Taking in is the initial stage, psychosocial stage after birth. The patient is taking it all in. They share their birth story a lot. That's normal. They share their birth story, they're taking it in, they are receptive to advice from staff. Taking hold, they are the parent and they are making decisions for their baby. Anyone see this in NICU maybe? This usually takes a couple of, yeah. They usually, okay, and this is normal. The third stage takes about a month or so, and that's letting go. They start to let go a little bit. Okay? All right. All right. So resting, we want to talk about ADLs, healing, evolution. Return to fertility. How quickly does fertility return, by the way? You know, it varies. It really varies. Unless someone is lactating 24/7 and has their baby with them every hour, every day, we can't really recommend lactational amenorrhea method. Lactation does cause increasing prolactin, and increasing prolactin suppresses. It suppresses GnRH, FSH, and LH, and it will suppress ovulation. So high enough prolactin levels can suppress ovulation. But for people who use lactational amenorrhea, it's only good for 6 months if they are available and nurse their baby anytime the baby wants to, as long as the baby wants 24/7. And that means no supplementation, and it doesn't mean pumping. Pumping is not considered equal. Are there very many patients who do that? Very many people in the US do it? No, not really. So therefore, we typically recommend that people wait till they get on a contraceptive method before they initiate sexual activity with a partner in which pregnancy is a possibility. It is safe medically to be sexually active once the bleeding has stopped. Remember that lochia rubra lasts for about 3 to 5 days, and then it turns to serosa and it's pink for another week or two, and then it turns white. Once the bleeding is gone, they are safe and they're healed and they're ready and rested and want to. Then it is okay to be sexually active again. But I have seen people come, I once had a patient who came back for their postpartum visit at 6 weeks. The patient was formula feeding their baby. And the patient laughed at me. She says, you know, I had sex this morning. And I said, you know, I'm seeing spin barkite mucus here. She was back 2 weeks later for her next new OB appointment. She never menstruated after giving birth. She got pregnant again quickly. So just to let you know, just occasionally lactation is not enough, and you can get pregnant again right away. And yeah, all right. Follow up, 1 to 3 days postpartum, they need a nurse appointment. It can be a home visit, postpartum clinic, or a provider clinic. There should be usually, it could be at 1 week, but most often it's 2 weeks. There's an incision check with the provider if the patient is post-op cesarean. They then have another visit at 4 to 6 weeks to check involution. The components of this assessment vary, but it will include psychosocial assessment, sleep, lactation, pain, reinitiation of sexual activity. I will tell you that half of my patients were sexually active with their partner by their 4 to 6 week checkup. So just for you to be aware that that is normal. Not everyone takes advice. Sometimes providers tell patients, wait till you come back in for your checkup. Are people very good at waiting when they're ready? No. This is normal bandwidth of being a human being, right? Normal bandwidth of being a human being. But if somebody has initiated sexual activity, we want to know, are you comfortable? If somebody had perineal repair, are they comfortable? Is it going okay? When someone is lactating, estrogen levels are also very low, so they often need lubricant. Estrogen is responsible for moistness in the vagina. So that's also a thing, right? Their chest and breast assessment, abdominal assessment, pelvic exam. We expect complete involution and any repair should be well healed. Contraceptive needs if needed, and follow up on their relevant concerns. Any follow-up. They may need an HAH or a CBC in the patient's post-hemorrhage, and a fasting blood glucose if they were gestational diabetic. Remember, people with gestational diabetes, 2/3 will develop type 2 diabetes. So we want to follow up and recommend that they stay on an ADA diet. Maybe lower calories now, but stay on an ADA diet and stay active to reduce the chances that they will develop type 2 diabetes, right? So kind of covered those already. All right. We're almost there. All right. So we have, I think, 2 more slides, if you'll bear with me. Baby blues. A week or 2 after the baby is delivered, it is very common for people to experience mood swings and emotional changes. Okay, this is normal. This is called baby blues. Okay. It is normal for people to cry at things that would not ordinarily make them cry. Okay. One of my mentors, the one who made the quilt in my office, when she gave birth to twins, she reported bursting in tears when someone passed her on the right on the highway. Okay, now no one should pass you on the right on the highway, but it shouldn't be that bad, right? Okay, right? Right? All right, telling tales on your instructor. I remember with my first baby, I was sitting next to my first baby and I saw an ad for selective service registration. And I'm like, I don't want my baby to register for the draft. And by the way, one of my grandfathers is buried in Arlington Cemetery in Washington, D.C. And it was a pilot in World War II, a decorated pilot in World War II. So it's not that we're not, yeah. So in any case, so that's, but that was baby blues, right? Now then, if it persists, mood disorders are very serious and very concerning. An analysis looking at postpartum deaths over the entire year postpartum found that suicide was the leading cause of death of gestational parents. This is serious, right? Baby blues, it lasts less than 2 weeks and it gets better and it's fine, right? They're okay. They can handle their ADLs and it's okay. But if they're developing symptoms that persist 2 weeks or longer, then we need to raise the question of depression. Okay? And they need our help. The Edinburgh Postnatal Depression Scale is one of the evidence-based strategies that we would use for monitoring and assessing patients for depression. Okay? And it asks about, I have felt happy. Most of the time, all the time, not very often, not at all. And it's an assessment over the past 7 days. Able to laugh and see the funny side of things. Look forward with enjoyment to things. Blame myself unnecessarily when things go wrong. You see, are you thinking out the things? Yeah. Things have been getting on top of me. Things have been so unhappy. I've been having difficulty sleeping. I felt sad or miserable. I'm so unhappy I've been crying. The thought of harming myself has occurred to me. I've been anxious or worried for no good reason. I have felt scared or panicked for no good reason. It's a scoring system, and based on the scoring system, maximum score is 30. Possible depression is 10 or higher. We always check for suicide thoughts. These are patients who need our help and our support. Okay, and it is important that we get them into care. Counseling and SSRIs work the best. The combination, counseling and SSRIs. Okay. There are medications that are considered safe for lactation as well. Okay. We talked for a moment about postpartum psychosis. Postpartum psychosis is when the patient having hallucinations or delusions. One of my colleagues had a patient, for example, who took their baby into the closet with them because they thought that worms were crawling all over them. And they were trying to spare themselves and the baby from the worms that they thought were crawling all over them. They were obviously having a terrifying hallucination and needed help. Okay. All right. And this is someone who needs care urgently and needs inpatient care and treatment. Okay. That psychosis, someone has lost touch and is having terrifying hallucinations or delusions. Okay. This can also be a dangerous state too. Be aware that PTSD is also a very real issue. Remember me pointing out this doesn't sound so gentle, how this seems pretty rough? Did you look at all those for hemorrhage, all those lists of things we might do to someone? Someone is experiencing all of that. We may have saved their life, but now they have to survive what we had to do to help them live. And that's incredibly serious. Nursing is struggling with we're struggling a lot with our staffing, but if ever you get a chance to just sit down with a patient and say, especially our patients who have had complications, this is good nursing care, and say, hey, I heard you bled a lot. Tell me about it. How are you feeling now? Sit down with them, put your hand on theirs, and listen. Okay? And let them talk about it. And get them to a provider who can provide them with the counseling that they need. Postpartum Support International is one of your resources in your site course. 9% of patients who postpartum develop PTSD. That patient on bed rest for days on magsulfate while we tried to induce their labor, right? That patient who bled too much, the patient who threw an embolus, right? They're all at risk. Even, for our patients who are survivors of sexual trauma, giving birth can renew that sense of trauma and lack of control. And this is incredibly important, right? So real or perceived trauma delivery or postpartum. I recommend you check out the site. It's a wonderful site. PSI is a wonderful site. So intrusive re-experiencing, flashbacks or nightmares, avoidance of stimuli, persistent increased arousal, like irritability, difficulty sleeping, anxiety and panic attacks, a sense of unreality and detachment. These are some nursing ones. I do not have enough time to give you justice on this, but I do, we do have some excellent resources. Please I'm also be able to talk. Thank you for your time today. I know I need to let you go. I will leave you with one quote that I had on my refrigerator in my parenting days. My children are adults now, but my mother had a great deal of trouble with me, but I think